Welcome to our webinar tonight. I'm glad that we are back here. As you know, this is our fourth webinar tonight. This week, of course. And as you know, we are talking about success stories, and we have more, actually one success story tonight, and it's going to be definitely interesting. And we have our special guest, Dr. Nadia Caroppo, is right here with us. She's been here with us before, and I'm very excited to have you back as our presenter. How are you feeling, Nadia? It's been a while, and I'm glad that you are back for sure.
Very well. Thank you, Caroline. I'm sorry, my voice is down today. So if there's something that you don't understand, please feel free to ask. Okay?
Of course. We are here, so remember, we will start with the case. Dr. Caroppo will definitely explore the topic. As you know, it's about recurrent implantation failure, and afterwards there will be time for your questions. So remember to put those in the chat section, and Dr. Caroppo will definitely answer. And if you have had a chance to already see some previous webinars of Dr. Caroppo, you probably know that it's going to be an amazing session. I am sure of this. So I'm very happy that we are able to meet here once again. And thank you all for coming. I know that some of you have already been with us this week, so I do hope that you have some more questions to ask. And yeah, just remember, go ahead, do it. We are here right for you to support you and to advise and recommend anything that might help you with your journey, of course. So that is it from me. Let's go ahead with the presentation, okay?
Thank you, Caroline.
Thank you so much.
Good evening, everybody. Okay, so today we're going to talk about successful pregnancies and recurrent implantation failures in previous treatments. Today's case study, it's about a couple who first visited us after 6 years of primary infertility. The general anamnesis of this couple is that the female patient, being 46 years old, had a long history of dysmenorrhea, and the particular case was that she referred higher quantity of bleeding and more pain with periods in the past regarding her actual periods. Okay, she underwent 3 pregnancies, 2 biochemical ones and 1 coronal ectopic pregnancy, and no term pregnancy. She was studied for implantation failure panels, uterine natural killers count that were normal, and immunological studies being the KIR and HLA haplotypes, which did not seem to be a problem right away. But she has had a past diagnosis of adenomyosis and endomyosis. Her partner is a healthy male patient with a normal karyotype, and the sperm count is totally normal. It's a no-somospermia, but he had a high simple chain DNA fragmentation of 67%. They were directly orientated to an egg donation program because of advanced maternal age, and they underwent 2 egg donation programs with 2 different donors in another clinic. They started in 2018. And all endometrial preparations, as you see, were done under substitute cycles, giving her estrogens, oral estrogens, and afterwards they started adding transdermal patches. Okay, the second embryo transfer, she had a biochemical pregnancy. Single embryo transfers were transferred. In the first 2 transfers and the third one, they started with also an immunological scheme with Neupogen shots, intralipids, and heparin infusions. And she had an ectopic coronal pregnancy. On the same year, she underwent a laparoscopy with a left salpingectomy, but they entered into the uterine cavity and sutured it. Okay, this may be a problem in the future, because after that, she underwent a surgical hysteroscopy, and an Asherman syndrome was discovered. Okay, Asherman syndrome is when you see scar tissue, okay, that sometimes just sticks the cavity, the walls, the uterine walls between them. And this adhesion syndrome was in the isthmus and the left ostium, okay, ostium. It's the osteomas where tubes are born, okay? So they were liberated. After that, she underwent another endometrial preparation, exactly the same as the one she had, the ectopic corneal pregnancy. And the interesting thing here that the transfer was very painful and it resulted in a negative pregnancy test. With the second egg donation program, she underwent exactly the same preparation, okay, with loads of estrogens, being vaginal estrogens and transdermal patches, because the endometrial lining did not grow much, okay? This time, they also used the immunological schemes with Neupogen, intralipids, heparin, and they added atosiban. Atosiban is a uterine contraction inhibitor that in some places is used, and in some papers published in literature, they see that the uterine contractions before embryo transfer are somewhat diminished. In our experience, we do not use it because we didn't have good results with it, okay? She had a single embryo transfer at day 3, embryo transfer, and other 2 embryos were vitrified. Negative pregnancy test, 6th endometrial preparation, exactly the same as the other one. Negative pregnancy, 7th endometrial preparation, exactly the same. Negative transfer, and the last the negative pregnancy result, okay? And the transfer was painful, and she bled right after the transfer. That's not good, okay? So she has a total embryos transfer out of 2 different donors, 8 embryos, okay? This is a very important implantation failure. So when they first consulted us, we just brought her in prepared as how, with the same scheme of uterine preparation with which they failed, okay? And what we saw was that she had a globular uterus, she had a retroverted uterus, diffuse cystic adenomyosis, okay, that was affecting the lining and the subendometrium. She had 2 subserosal leiomyomas that were not a problem, okay, in terms of implantation. A very thin endometrial lining, which was not trilaminar, okay, and a very small cavity. And a 3D ultrasound scan, okay, it showed to be a tubular uterus, okay? And we saw that in her right ovary she had endometriosic implants, okay? So the diagnosis was a female cause, being by the diagnosis was adenomyosis, endometriosis, Asherman syndrome, okay, and an endometrial factor, because the endometrial lining did not grow sufficiently. So we designed a plan, okay, to study, treat, and transfer. We decided to perform a pelvic MRI in a luteal phase, that means under the effect of the progesterone, treat the uterus, and then synchronize her preparation with fresh donor, okay, and low dose of estrogens to prepare uterus. And because of the previous diagnosis of Asherman syndrome, we would have performed a diagnostic hysteroscopy previous to embryo transfers, just to make sure that the uterine cavity and the endometrial lining were okay. This is the pelvic MRI, okay? You see the 3 cuts that we use to see and diagnose, okay? These, it's one of the diagnostic tools we use, okay? And as you may see, okay, in your right, okay, she had a cyst here, and the cystic adenomyosis, and this was the place on the left. You see like a round area where the corneal ectopic pregnancy was, and the suspicion of Asherman syndrome was. In a longitudinal cut, you see that there was a low expansion of the endometrial lining that was relevant, because in the ultrasound when she came in, it was in 2, okay, and in a transversal cut, we see the leiomyoma, that it's a subserosous endometrioma, so that's not important, but we still see the cystic adenomyosis. So the plan was to do a surgical medical treatment. We did a hysteroscopy with a metroplasty, and during the diagnostic and treatment, surgical treatment procedure, we saw that she had an endometrial polyp in the anterior wall, subendometrial cystic adenomyosis in the right coronal area, an arcuate uterus with prominent lateral walls, and tunnelized ostia. This means that her uterus was not really tubular, but it was a Y-shaped uterus, okay? And she had left coronal synechia and moderate fibrosis, okay? These are the pictures of the pre-surgery and post-surgery, okay? Just to make sure, just show you the difference, okay? If you see the two lower pictures, you see pre-surgery, this is the polyp, okay, the white thing that you see in the middle, and then the lateral one, okay, you see the small cuts that are done in the subendometrium, okay, just to expand the walls, okay, and work through that subendometrial lining to create a good inflammation and increase the chances of implantation of those embryos, okay. In the walls, we perform some cuts, okay, just to open the cavity, that is the metroplasty, okay. This has to be done very carefully and by expert hands, because if not, some damage can be done to the uterus, and we may not get pregnant, okay, because sometimes they do not heal properly, these uteruses, okay. So after that, we decided to give her trimestral analogs, okay, just to make her ovaries get at rest and try to dry out all the cystic adenomyosis that she had in the thickness of the muscle. 2 months after that, we just make sure that all those adenomyosis cysts were dried up, and we asked for a vaginal scan. And as she had a regression, a complete regression of those lesions, okay, we decided to go ahead and do the endometrial preparation, synchronize her with the donor, and go ahead eventually with a fresh embryo transfer. So we started on daily 1 milligram of estrogen vaginally, and we gave her pentoxiflin, that it's a vasodilator, to make sure that correct flood of blood arrives to the endometrial lining, and this is something that is given to very hard uteruses, okay? And high dosages of vitamin E, that it's another compound that we use to increase the endometrial lining, okay? We did a vaginal scan. The endometrial lining was thin, but it had a good aspect, okay? So knowing that she had in the past very thin endometrial linings, and that the aspect echographically was very nice, we decided to perform the diagnostic hysteroscopy in the consultation, okay? And we saw that she had, again, a synechia in the cervix, okay, in the internal ostium, the internal cervical orifice, and in the left ostium, where she had the previous coronal pregnancy, and that they were liberated. Nonetheless, the endometrial had a polypoid aspect, okay? So we had to rule out another factor that could have been implied in implantation failures, that it's endometritis. Finally, the results of the biopsy were negative for chronic endometritis, but positive for bacterial endometritis. And there was a bacteria that's called Streptococcus galactiae, that it's very common, okay? It's seen in the natural flora of the vagina and the uterus, but when it's over, it grows in a much higher percentage regarding the lactobacilli that you are going to see it afterwards with me. Okay, we have to treat it, okay, because the flora is not balanced, and it's an agent that can irritate the endometrial lining and cause implantation failures. So we decided to provoke a period and restart the uterine preparation. This time we gave her less estrogens, okay? The same scheme with pentoxiflin and vitamin E, oral and vaginal probiotics. We did the endometrial, the ultrasound scan, and their lining was super nice. It's true that a perfect lining should measure between 7 and 8 millimeters or 9, okay? But some patients that even with 6 millimeters and a very good aspect in ultrasound and hysteroscopy are capable of getting pregnant, okay? You have to just personalize that and know that there are some women that will never give you very thick endometrial linings, okay? We did another diagnostic hysteroscopy and the endometrial lining was perfect, okay? So we started with luteal phase pores, with vaginal pessaries, intramuscular progesterone, and we gave her heparin, but just after the embryo transfer and until the pregnancy test, okay? Only 10 days. Why? Because heparin before, during endometrial preparation can damage, okay, and can provoke bleedings during embryo transfers, okay? We did a uterine scan before we thought the embryos just to check on the endometrial lining. We saw good endometrial compactation, a very good aspect of 6 millimeters, and we decided to thaw the embryos because we were not capable of doing the synchronized here. We had to freeze embryos because we were not capable of going ahead, okay, and do a fresh embryo transfer. So we thawed 2 super blastocysts, super quality. We did a very good embryo transfer because we did mock embryo transfers first to have it very well assayed just before, just to know exactly how we have to get inside the uterus before we go for an embryo transfer, okay? So this is a success story. So here we have pregnancy details, okay? So this couple had a positive pregnancy test, very high HCG test, corresponding to a twin pregnancy, okay? The fact is that she had some small hematomas and bleeding during the implantation process. She was indicated bed rest, okay, because she had a very irritable uterus, okay, and these hematomas are typical of women having a severe adenomyosis, okay. During her pregnancy, everything went well until the 25th week of pregnancy that she was admitted at the hospital because of a shortening of the cervix, okay, because of the twin pregnancy and because of her severe adenomyosis, okay. So IV contraction inhibitors were administered, corticosteroids to mature lungs in babies, magnesium sulfate to protect neurologically the babies, and afterwards she was discharged with daily subcutaneous progesterone injections until the C-section was programmed, okay, because the babies had a good weight. And things were not going the right way, okay? She started with mild hypertension, so a C-section was programmed. And during the C-section, mild acratism, okay, that it's an abnormal placentation, okay, when the placenta invades not the right way, okay, and sticks, okay, to the uterus was seen. No blood transfusions were needed, and the babies were healthy newborns. They were admitted to the ICU, neonatal care unit, because of low birth and because of prematurity, but they were discharged, and they are now very healthy and beautiful, okay? And we know that for a fact because we are in touch, okay? So what should we do when we have recurrent implantation failures? Basically, have a good diagnosis. That's the first part, okay? And in this case, the adenomyosis is a chronic benign disease that it's only cured with menopause, okay? And this implies ectopic endometrial and stromal glands that generate a thicker muscle, okay? So uterus tend to be more rigid or thicker, okay? It depends. It has a behavior that's very dysmorphic, okay? And there are different types of adenomyosis, cystic, scary, okay? It generates scars, something, or a mixture of both. And this pathology is linked to many things, okay? It's basically related to age, to aging, to painful periods. And this implies biomechanical factors, okay? How the uterus contracts to get rid of the period, okay? Especially in retroverted uteruses, okay? Or women who experience severe dysmenorrhea during their life, okay? inflammation issues, okay, an appendicitis, a tubal pathology can start all these things. It's very linked to autoimmune disease, intolerances, okay, to lactose and gluten too, okay. So there are several coexisting factors that can contribute to adenomyosis. Which tools do we have? Vaginal scans, 3D scans, pelvic MRI, and hysteroscopy. I'm sorry. But we should never rely only on one diagnostic tool unless we don't have the opportunity to go ahead and perform other scans. Sorry. We have surgical and medical treatments. This is only personal. I'm sorry, I have my voice down today. So that is personalized according to the type of uteruses we have, okay? And we tend to just personalize. What we have to do, because there's not one woman equal to another one, especially with these pathologies, okay? So the adenomyosis may be totally asymptomatic, or you can have any type of other symptoms, just abnormal bleeding, pain, or reproductive failure, or have debut of discover this because you do not get pregnant or you fail with pregnancies, okay? And what's interesting and very important is that adenomyosis and endometriosis can coexist in a high percentage, okay? So it's very, very common to see women who have endometriosis and then they have the uterus affected and vice versa, okay? So this is very important to be kept in mind, okay? The other aspect regarding this case study, okay, it's endometritis, okay? It's a chronic inflammation of the endometrial lining that it's diagnosed with a presence of plasmatic cells, of abnormal cells in the endometrial stroma and or, okay, bacteria, okay? This is only diagnosed with diagnostic hysteroscopy and with biopsy, okay? And it's not seen in ultrasound, okay? Of course, this decreases the receptivity and implantation of our embryos, and the prevalence in the general population is very variable, okay? It's, as you see here, between 0.8 and 19% of women have this, okay? It's true that some women have endometritis, but they still get pregnant and they have ongoing pregnancies, okay? So it's very common to see endometritis in women with endometriosis and adenomyosis, okay? Because everything is altered, okay? The functionality of the endometrial lining and the uterine function are very, very much altered, okay? So we see this a lot, okay? These are the diagnostic patterns, okay? When we do a hysteroscopy, inpatient hysteroscopy, where you see polyps, you see red spots, white spots, all the things that you see here. When we see them, we say, this is not correct, okay? So we tend to do biopsies or directly treat patients because we know what it's perfect. And this is a perfect endometrium that gets pregnant, okay? This is super nice. When we see this, we just go ahead, okay? And this other slide is related with the fact that the uterine and vaginal flora is very, very important, okay? Because the uterine cavity and the vaginal cavity are not aseptic cavities, okay? So there is a population of bacteria that have to be there, but lactobacilli have to prevail over all the other ones because they are the regulators that everything will be okay. Okay, when you see a dysregulation in the endometrial flora, okay, you tend to have more endometritis and implantation failures. But this is not the only thing that you have to keep in mind. It's one other thing that we can improve eventually. That is why we always give oral probiotics and sometimes vaginal probiotics in those patients who have a diagnosis of an abnormal uterine flora, or they come from endometritis, or we have a suspicion of endometrial factor, okay? Nonetheless, regardless that in our clinic we always give probiotics. Okay. And not least important is how we do the embryo transfer. Okay, it's not only good quality or euploid meaning normal, chromosomically normal embryos. Okay, but how you do technically that embryo transfer. Okay, because you don't have to have any bleeding, nor feel pain, nor feel during the procedure or 48 to 72 hours after the embryo transfer. That does not have to happen. Why? Because if you do an embryo transfer when you feel pain, the uterus automatically contracts and will spit out everything it has inside. Okay, so that is very important, and that is why we do mock embryo transfers, just to make sure that we know exactly how to get inside the uteruses, because sometimes you are very surprised, but some women do not get pregnant because they have very difficult embryo transfers. Okay, so this is something that we always do, always, to know if it's difficult, how we have to get inside, or if we have to do something in preparation for that embryo transfer. Okay, so this is the last thing. Okay, in conclusion, okay, a correct diagnosis and a correct treatment is the keys to success to get pregnant. Okay, getting pregnant is very difficult. It's not just having a sexual intercourse and that's it. Okay, that happens to a very small portion of the population. Okay, so the basis of everything we have is having a good diagnosis. And if we have a good diagnosis, we know which enemy we have to fight against. Okay, because what happens usually is that the uterus is the best incubator and it's the forgotten piece of the puzzle. Okay, so we see lots of cases with normal embryos transferred. We had last week a patient who failed 13 normal embryos, and it's because the uterus is not correctly prepared, conditioned. Okay, so that is very important to keep in mind. Okay, so that's it. Thanks a lot. I hope you enjoyed this presentation, and nothing, Caroline. That's it. I don't know. We can go ahead if you want.
Definitely. Thank you so much. Indeed, another amazing case for sure. Tough one, but thank you for explaining all the details. And of course, you are very right. It's time for the questions. As you can see, there are plenty of questions right here. For those who haven't asked yet, you know what to do. Type this in. Dr. Caroppo is here to help you. And before we start, there is also a comment from Claire. So Claire, I just wanted to say congrats, and we are very happy to hear such news. And thank you so much for that comment.
A big hug to you, Claire.
Excellent. I just needed to say that for sure. Thank you so much for sharing, Claire. I think that means a lot to all of our patients, indeed. So thanks. Okay. And well, now let's get going with the first question that we've got here.
Okay.
Just a second, sorry.
Yeah.
From Natalia. Interesting case. Was the embryos PGTA tested? If not, still it would be good quality donor embryos. Why would you transfer two and impose a risk for the baby and the lady? What were your considerations?
Okay, PGT testing is not advised to do when you have donor eggs. Okay, when you come from an egg donation program, because the younger the eggs are, the lower probabilities of having abnormal embryos. Okay, so that's not something we advise to do unless there is the male partner that has an alteration in the chromosomal count. Okay, that needs to be tested. We do it, or unless the couple has the desire to go ahead for a PGT testing. What we would transfer to, because of her past medical history, okay? She had biochemical pregnancies with single embryo transfers and a coronal ectopic pregnancy. And after that, she never got pregnant with one embryo transfer, okay? So you have to personalize that, okay? It's not the nowadays, what it's throughout the world in every clinic, the gold standard will be to transfer one single embryo, okay, and diminish the risk of a twin pregnancy. That's correct, okay. But sometimes you need more embryos just to get pregnant of one, okay. And it's in this couple's particular case, they got pregnant of twins, okay. In my head, I told them, I'm transferring two because you will get pregnant of one with all your past history. But the fact is that she was so correctly prepared, okay, that she got pregnant of twins, okay.
So that just simply worked the best way, right?
Yeah.
So thanks so much.
Something that we usually, some couples have to have a single embryo transfer. Some others are not advised to do a single embryo transfer. Okay, so it depends on the couple and the past history, okay, of those patients.
Thank you so much for that, of course. And there is another question from Natalia. Second question, high DNA fragmentation with the male. Did you do anything special to the sperm to improve quality?
Single chain DNA fragmentation is perfectly sorted out by ICSI, okay, when you choose the sperm that looks the best, moves the best, and has a normal structure, okay? When you have double strand DNA fragmentation, there are several techniques that can be used, like the fertile chip, okay, the max, other things, okay, to sort them out, but you have to do them. You may do them only if you have a normal count. If you have a male factor, that's not good to do, okay? And in their particular case, they had very good embryos, so that DNA fragmentation was not a problem for us, okay? And knowing that it's single strain, and by choosing those sperms, you just rule out the DNA fragmentation. That's it. We didn't use it in their case.
Excellent. Thank you so much for the clarification. And there's a thank you from Natalia for you for that as well. Okay, let's have a look. A bit of a longer question here. I'd like to share my case and ask some questions. I'm turning 40 in June 2022. I've done one IVF treatment with 3 embryos, 2 of quality B and 1 C, but all 3 times the pregnancy test 2 weeks later was negative. Apparently all is good on my behalf and my partner's. My question is, what could be the reason for this, and what would be your recommendation as of what should be the next step to take?
Sandra, here I think that we have maybe, I don't know if your embryos were day 3 or day 5 embryos, okay? Maternal age is a very important factor. Sometimes it's a history of abnormal embryos, okay? And sometimes it's the famous unexplained fertility, okay? With apparently no diagnosis, everything looks fine, but it does not look fine. And that infertility of unknown origin is generally adenomyosis and endometriosis. Okay, so I hope you find some guidance, okay, and see if you can get unknown. Yeah, okay, it's what I told you, Sandra. Okay, unexplained fertility. Okay, it's usually a uterine problem, okay? Nonetheless, being 40, there is a good chance that sometimes embryos are not healthy, okay? And what happens is that in 70% of failures in implantations are because of abnormal embryos, okay? In the rest 30%, okay, you have to study more things. And in fact, if you have unexplained fertility, search some advice, because probably there can be some signs of adenomyosis or endometriosis that are very subtle, but that they are making your uterus maybe non-functional. I don't know now because I don't have all your tests to see, okay? But those are the things that I think that may be happening right now.
Okay, thank you so much. And let me just go to the follow-up from Sandra right here. Okay, so could be abnormal embryos or the things. Yeah, okay, thank you. Sorry, I didn't see it on time, but you've explained that already, of course. Yeah, thank you.
I think
let's have a look at there's another question here. How would you treat mild endometritis? I was given 2 types of antibiotics. Should I repeat the hysteroscopy?
It depends if they. It depends on which type of endometritis if you had. If it was a bacterial endometritis, they usually do an antibiotic scan to see to which antibiotic is sensitive. That bacteria, okay. But if it is a mild chronic endometritis that has nothing to do with bacteria, endometritis, we usually give anti-inflammatory schemes with different types of medications, being ibuprofen, streptokinase, azithromycin, okay, and oral probiotics, okay. If you had diagnosis and been treated 2 times, it would be good for you to undergo a diagnostic hysteroscopy just to rule out that the endometrial lining looks like the one I told you, okay? If it's good, that's gone, okay? You don't need to do any other biopsies.
Again, thank you so much indeed for yet another question. And now let's have a look at this presentation. I had 11 high-quality embryos before getting successful pregnancy with HCG uterine injection at point punction and atosiban at transfer. Sorry, I'm not sure. I used to have mild pain at transfer. Was I then contracting at transfer? Why is that so difficult to get atosiban?
Thank you, Clarice. At punction, okay. Atosiban is not something that it's largely used because uteruses, it's a contraction inhibitor, and that we use in preterm in women who enter into labor with a preterm labors, okay. The uteruses have low receptors for those medications, and it has proven in more than lots of cases, okay, that those receptors are nearly inexistent, okay, during the endometrial preparation phase, okay, with a uterus that it's not pregnant and it's not overdue in the long run, okay, with the pregnancy. Those receptors generally appear around week 20 of between week 17 and 20 of pregnancy, okay? It's very difficult to get atosiban because it's very, very expensive and there is no scheme implied in giving it, okay? So we do not know the exact dosages, nor the scheme to how to administer it, okay? So it's very difficult. We used it in the past and we had no differences in getting pregnant women the regular way, let's say, with the endometrial preparation we do, versus using atosiban too, okay? I don't know if in your case that was what made the difference. Maybe yes, okay? So your uterus contracted a lot more and so you benefited for it, okay? So I'm not telling that it's something that shouldn't be used. I'm telling you that sometimes you have to choose to who administer those medications, okay?
Again, thank you so much for yet another advice, of course, here. And of course, there are more. Let's have a look, okay? So Michelle is 35, okay? And here's more details. I'd like to share my case. I had 2 negative transfers before having my right fallopian tube removed, cyst on the left ovary and myoma on the uterus. I just did a 3rd transfer and it came up negative. I was diagnosed with adenomyosis. What should be the next step? Thank you. Good quality embryos, by the way.
Okay. Let me see, Michelle. It's a lot of things you did. Okay. Wait, I'm sorry. I lost the image. Hi, Caroline?
Sure, we can hear you. All is okay.
Okay, sorry. I'd like to say, to tell you this from having my right fallopian. Remove cysts on the left ovary and myoma. I just did the 3rd transfer and it came out and I was adenomyosis. What should I do? Okay, I don't know which type of endometrial preparation you underwent, uterine preparation. Okay, maybe just the removal of the fallopian tube and the cyst and the fibroid were not enough. Okay, so sometimes we have to do a hysteroscopy like we did on our patient just to remodulate the cavity and maybe treat you with medication just to do another type of uterine preparation, okay? Especially if you had very good embryo qualities, okay, and never had a positive pregnancy test, okay? So I think that your case should be just sorted out from another point of view and just study it a little bit more before going ahead with an IVF or embryo transfer. Okay, but the diagnostic hysteroscopy is not the same as the surgical hysteroscopy, okay? And if you do not know what you are going to look for, you may see that the diagnostic hysteroscopy is normal, but it's not normal because sometimes the cavities are not normal, okay? And you see white walls, you see arcuate uteruses, the concave uteruses, okay? Convex, I'm sorry, a tunnelized osteo, and you don't know that that is abnormal, okay? And it's a consequence of aging and the adenomyosis. So you have to know what you're looking for to know what you have to treat, okay? Diagnostic hysteroscopy is done only to see some things, okay? But not treat them. We have loads of patients who have undergone diagnostic hysteroscopies telling normal cavity, and then you see it and it's not normal, okay? But this, not all gynaes know how to identify it, okay, and treat it. That's the most important thing.
Okay, thank you, of course, from Michelle for you right here as well. And let's have a look. Another question is, there are like two parts of it, okay? So let me just give me a second. Okay. Here it is. My wife has had 4 transfers, none of which have been successful. We have just had the Emma, Alice, and Era scans and are waiting for the results. We think it's an immune issue. What would you suggest we do next? She is 32.
Okay, next step. If you have any embryos left, or if you have to undergo another another IVF round, I suggest first of all to do the PGT testing, okay, pre-implantation genetics testing, to rule out that it's not an embryo problem. Second thing, the Emma Alice tests are the tests that that will show how your microbiome is, okay, meaning that if the lactobacilli proportion, etc., is okay, or if you have endometritis of some kind. Okay, the error test, personally, I don't use it, and here in the clinic we do not use it because we do not rely on it. It's not a test that it's very useful for us. Okay, I'm not telling that. No, nobody has to do that. Okay, just wait for the results, and maybe the results may be normal. Okay, so first of all, just see if you have normal embryos. Second thing, okay, study the uterus and the fallopian tubes a lot more. Okay, even if the fallopian tubes are bypassed in an IVF round, okay, they may be dilated or affected, and that may give you negative results. Okay, and study the uterus a lot more. Okay. And see what can be done better, okay, just to go ahead and have a successful embryo transfer, okay? But the first thing is a PGT, pre-implantation genetic testing.
Okay, thank you. And there's another question from Bo. So you mentioned the pain during the and after transfer is not good. When my wife has the transfer, she has to go under anesthetic as it is so painful. Why would this be?
That may be the cause of her not getting pregnant, okay? Okay? Why? If she has to undergo anesthesia, you do not have the feeling of the patient, okay? When we do embryo transfers, we always do them, okay, awake, okay? There's no woman who undergoes an embryo transfer with anesthesia because they have to tell us, I feel that you're touching, I feel that something is getting inside, I feel pain, I feel itching, I feel something that's stinging me, okay? So a bad transfer may not get you pregnant, okay? And that may be because the cervical canal is difficult to canalize, okay? And if you do not have the best apparatus, okay, the best cannons, or different type of cannons, okay, an essay, mark embryo transfer first before you have the embryo thawed, okay? It's very difficult sometimes to get pregnant. We have one woman who underwent I don't know how many embryo transfers. She was 36, and the cause was a bad embryo transfer. Okay, so that may be the cause.
Okay, thank you so much for that. And actually, let me go to the next question, because actually this is kind of a follow-up matter, actually. So one of my transfers was also painful. My cervix is very narrow, as I've been told. Don't know if this is your, I mean, sorry, if the previous patient case, right? Could that be the cause of the pain as well? Can you comment on that?
Of course, if the canal it's very narrow, okay, you may not pass perfectly, okay, with the canyon. Sometimes we had to use cervical prosthesis, okay, with a small tutor, okay, inside, just to make sure that the canal was correctly dilated before we had to do an embryo transfer. When we did the hysteroscopies, okay, we just put the tutor in just to make the canal a little bit wider, okay, just to make sure that we went inside perfectly, okay. We had 3 patients like that, okay, but it's something that you have to think about, okay, when you do an embryo transfer. So yes, a narrow canal. Maybe there are some cervical cysts also that can be a problem, okay, to sort out those cysts, or include, you can have also adenomyosis in the cervix, okay, and that may cause a difficult embryo transfer, okay, and the cause of pain, yes, of course. If you cannot canalize correctly the cervix, you will have pain, okay. It's like inserting an IUD, okay, an intrauterine device. You will have pain if it's not correctly dilated and you don't know how to put it in, okay.
Thanks again for the explanation. And now the question is, what oral and vaginal antibiotics do you usually prescribe?
It depends, okay. It depends on I said that before. It depends on the type of bacteria that you use. Generally, the most prevalent bacteria in endometritis are Enterococcus, Escherichia coli, okay, that they are very related to an altered flora in the intestine, okay. They live in the intestine, okay, and they colonize the vulva and the vagina, or cause recurrent urinary infections, okay. In those cases, we give ciprofloxacin, I'm sorry. But in other cases, it depends on the agent we see. If we treat chronic endometritis, okay, that it's in a specific entity, okay, meaning that there's no cause other than you see the plasmatic cells, we just give azithromycin 3 days, okay, in a row.
Okay, thank you once more for that. Next question is here. Sorry, I'm 48 with 4 failed donor transfers. I had miscarriage at week 10 with heartbeat prior to donor route, and 5 failures with my own embryos. I had stage 2 endometriosis diagnosed after this miscarriage in 2016. In my last transfer, 2021, I was prescribed aspirin for 100 post-transfer, along with Lexane, prednisona, and hydrochloroquine 400, and I have very little time. Should I test again for endometriosis?
Okay, first thing, the most important thing, that the miscarriage was at week 10, and before that you had a positive heartbeat, okay? So probably there's a problem in the invasion of the placenta, okay? So that may cause a miscarriage, okay? And if you have endometriosis, you will probably have adenomyosis, okay? What you should do is, if you did not get tested to see if the fallopian tubes were okay or not, do a hysterosalpingography, okay? To see if the fallopian tubes are okay. And if not, just undergo a vaginal scan with someone who understands about adenomyosis, okay? And eventually a pelvic MRI during the luteal phase, just to make sure that everything is okay. Clexane is used, as you saw with our patient. Prednisone can be used when you have very inflammatory adenomyosis. Hydroxychloroquine also is used as an immunomodulator. We do not use it, okay, because we do not know how to use it. but it's true that a lot of immunologists just give you that medication. We do not know which impact it really has in letting those embryos implant, okay? Because if we have loads of women having those schemes that do not get pregnant, it's a fact that immunology is very, very important, okay? Because it's accepting a foreign body, okay? And the uterus and your body has to protect that baby from the white cells just wanting to destroy it, okay? Because if it's an abnormal tissue, it's like a transplant, for you to understand, okay? So we do not know how much that helps or not, okay? So I don't know if I would use it or not, okay? It does not. There's some reports that say that there's high risk of fetal malformations in the first trimester of use, but that's something that we do not know. For sure, what I advise you to do is to search for gynae who understand lots more of endometriosis and adenomyosis, and just get a good diagnosis, okay? Because your miscarriage is a little bit, it's too important to just let it to faith, okay?
Thank you so much for yet another advice. And we will go back to our previous patient, okay? And let's have a look. It's about the Otosiban, right? So it was quite cheap in Switzerland. Here was the protocol: injection of Otosiban just before embryo transfer. Single dose has shown to have a positive impact in patients with recurrent implantation failure. Anything you can add?
No. It's used. I'm not telling that it's not, does not have to be used. It's something we do not use. We didn't use in our patient, and she got pregnant. So I'm not telling that this does not have to be used in any patient. Of course not. Here in Spain, it's a very expensive drug. Okay, so in other countries, other drugs are much more cheaper than here. Okay, so I'm not telling you that it's not useful. Okay. Published literature, it's very heterogeneous in terms of results. Okay, so just one paper will not change a physician's mind in terms of treatment. Okay, I'm happy that it functioned for you, that it was something that helped you. Okay, but I'm not telling you you do not have to use it. Okay, I'm telling you that some patients are candidates to use it, and some other they won't have any benefit from it.
Of course, perfectly understood that. So thank you so much. And how about vitamin E for implantation? Is it important?
It's a compound that we give because there are lots of things that you can use in refractory. Refractory means endometrial linings that do not grow as they should, and vitamin E is one of them that we use, but to make the lining a little bit thicker. Okay, it's not for implantation, it's just to give a little bit more of energy to that blood flow and to that arrives to the endometrial lining, and for that endometrial lining to grow. Okay, it's not directly implicated in implantation.
And again, thank you for this. And we will be coming to an end slowly. So of course, if you have more questions, this is like the final call for those. Go ahead, type those in. And the question is from Natalia. I'm 41, had 4 failed transfer, 2 cleavage stage, 2 blastocysts untested, not allowed by local regulations. 1 was biochemical. My husband has normal spermia, but DNA fragmentation 29%, upper norm limit. We had ICSI, I guess. The next possible option is TESE. Would it be a reasonable step? All the rest is okay.
With your age, Natalia, my advice would be to do a PGT, pre-implantation and genetic testing. First thing, okay? TC, it's not a super option. Okay, it may be an option. It's described that it can diminish the DNA fragmentation, okay, to select better the embryos, the sperms, okay. But my first advice would be to do a PGT, okay, pre-implantation genetic testing, okay, because you had a biochemical pregnancy, okay, and maybe it's an embryo problem given your age, okay.
All right, thank you for yet another advice. And I believe that that was helpful. I'm just looking because, of course, someone is typing. So let's give it a second and see if we have more questions, as you know. Yeah, okay. Okay. So there's a comment from Natalia. Okay, thanks. Have to go abroad then.
I'm sorry. Yes, there are some countries that
True.
Pre-implantation and genetic testing. It's true. It's something that we do not understand. Why not? Maybe for ethical, moral, religious reasons. So it's respectable, okay? But sometimes it's needed.
Of course. Thank you so much for that. And as I mentioned, we'll be slowly finishing. And in the meantime, there are plenty of thank yous already. So let's show those. I know that someone is typing, so let's wait. As you can see, good structured presentation. Learned a lot. Glad to hear that as always, right, Dr. Nadia? That was useful. And there's one more comment. Please pass on my thanks to this truly wonderful doctor. Very interesting case. Thanks to this wonderful lady. We are currently bathing our twins. So. What else can we ask for, right? So
I'm so happy to hear from you. Great.
Exactly.
Give them a big kiss for me.
Definitely. Congrats. As always, we are always happy to hear such news. So the more we have those news, the more happy we are. So don't hesitate.
For us, that's what keeps us being better and learning each day. So that's great. That's great.
Exactly. So thank you so much. And we will be finishing actually. So everyone, thank you for sharing, okay, all the comments and also for those questions. You are definitely, it is a hard journey for you. So I do hope that those webinars are just helping up, even if a bit, you can find some more details, you can learn a bit more, and of course you can ask your questions. And like Dr. Caroppo, I'm sure she was useful for you. So Dr. Caroppo, thank you so much for joining us. As I mentioned, I knew it was going to be a great session, and I wasn't wrong for sure. So thanks a lot, and I'm looking forward for the next webinar, that's for sure. Anything else you would like to add to all our patients?
Thank you. Just don't be afraid to ask a second opinion, okay? To any doctor, wherever you are, because sometimes you know in deep inside of you, you know that something's not good, not correct. Okay, so just search for some advice if you feel that there's something that it's not correct, and be sure that if you need extra help, there are lots of super good colleagues that can help you. Okay.
Amazing. Thank you so much. As you know, it has been recorded. You can go ahead on our website, mayavivances.com, where you will find this tomorrow, but also you can have a look at the previous webinars with Dr. Caroppo. I'm sure you will find it also interesting and useful. And well, as you know, this is our final webinar this week, but don't worry, we'll be back next week on Monday. There are 4 more webinars coming up, so don't hesitate, sign up, and more topics to discuss, more cases to discuss as well. So thanks a lot, everyone. Enjoy your weekend. And Dr. Caroppo, I will see you hopefully very, very soon here, right?
Okay, Caroline.
Thanks so much. Take care, everyone. Have a good evening. Bye.
Bye. Bye-bye.